It is a Tuesday night. Clinic hours ended hours ago, and somewhere right now, a physician is sitting at their kitchen table working through a backlog of patient messages. None of it is reimbursed. We call this pajama time. It is often treated as a personal time management issue, but it is actually a systemic, structural failure of how outpatient medicine is organized today. The math is unforgiving. Physicians seeing more than 40 patients a week now average over 15 hours of off-hours electronic health record time. That is nearly 2 full shifts of unpaid, unscheduled work every single week. Take a look at this breakdown based on American Medical Association data. Out of a reported 57.8-hour work week, 13 of those hours are dedicated strictly to indirect patient care and triage. The patient inbox sits directly on the middle of that bucket. The result is an exhausted workforce. In 2024, 43.2% of physicians reported experiencing at least one symptom of burnout, with excessive electronic inbox burden consistently cited as a primary driver. The patient portal was originally marketed as a simple convenience. Without a system to manage the flow of requests, it became a massive administrative liability that actively damages practice sustainability. Patient portal message volume exploded in 2020. The problem is that it never came back down. To fix this, we have to look at the AMA's data on inbox triage, which reveals a critical metric, the 10% rule. Only 5 to 10% of incoming messages actually involve complex matters requiring a physician's direct attention. This pie chart dissects typical inbox volume. While this 10% slice needs a doctor, the dominating 90% is routine refills, scheduling, insurance, and lab notifications. Consequently, practices force highly trained clinical minds to perform low-value administrative routing instead of practicing medicine. The solution to this mismatch is systematic delegation. This is a strict framework designed to intercept, route, and resolve non-clinical messages using trained staff before those messages ever reach the provider's screen. We know this works. The AMA documented a case study where a physician group implemented systematic delegation and successfully reduced their primary care in-basket volume by 25%. An overflowing inbox is not a medical problem. It is a routing and delegation problem, and it requires dedicated support infrastructure to solve. The standard practice management response to this crisis is straightforward. Hire local, in-house medical assistants to handle the triage load. But that creates the hiring spiral. A practice recruits someone, spends weeks training them on specific electronic health records and protocols, and then watches them leave for a larger hospital system offering higher pay within a year. Medical Group Management Association data from 2025 validates this, showing 29% of practices reporting increased staff turnover compared to the prior year. Front office and medical assistant roles remain the most common hotspots. Look at the financial impact of turnover. You get months of steady productivity, but when the employee leaves, replacement costs 6 to 9 months of their salary. That triggers a massive $20,000 to $30,000 penalty per departure. Beyond the hard costs, you suffer an immediate operational coverage gap. While you recruit a replacement, the entire triage load drops right back onto the physician's shoulders. The underlying limitation is geography. When you hire locally, your talent pool is strictly limited by a daily commuting radius, making experienced triage talent scarce and expensive. Relying on a traditional, localized in-house model guarantees cyclical disruption. It is the most operationally fragile approach a practice can take to manage its inbox crisis. The modern alternative to physical staffing is outsourcing to specialized healthcare-trained virtual teams, like those provided by Staffingly. These outsourced teams operate differently. They arrive completely pre-trained on healthcare workflows and HIPAA requirements long before they are ever assigned to your practice. Staffingly's infrastructure plugs directly into more than 50 major electronic health record systems seamlessly, meaning there is no technology barrier to overcome. What makes this virtual workforce highly efficient is a built-in layer of technology called AI Smart Routing. This flowchart illustrates the process. The AI layer instantly evaluates every incoming message, automatically routing it to the team member with the right expertise and capacity. Simultaneously, it conducts real-time SLA monitoring, flagging potential risks before a patient experiences any delay. It is a deliberate division of labor. The AI handles the high-volume mechanics of routing and prioritization, allowing the experienced human staff to focus entirely on making nuanced clinical judgment calls. Trading a physical office presence for a virtual, AI-augmented team gives you scale. It ensures consistent coverage and permanently eliminates the burden of continuous localized retraining. Operational efficiency is important, but practice owners ultimately have to navigate the bottom-line financial arithmetic before making a structural decision. An in-house medical assistant looks like a $35,000 base salary on paper, but when you add benefits, payroll taxes, office space, management overhead, and turnover costs, the math changes. The actual, fully loaded cost of maintaining one in-house clinical triage position totals $60,800 per year. Now compare that to Staffingly's outsourced virtual assistant model. Benefits, training, management overhead, and backup coverage are entirely included in one flat rate. This chart breaks down the comparison. The in-house bar climbs to $60,800, while the outsourced position holds steady at exactly $21,600 per year. That 64% cost reduction is a $39,200 difference, serving as a direct injection of capital back into your practice's margins. The return on investment is not a multi-year projection. Practices that implement this model track measurable workflow results and cost savings within 60 to 90 days. This financial trade-off is about converting high-risk, unpredictable overhead into a stable, highly capable, and lower-cost utility. This solution is specifically built for mid-size outpatient practices that are actively bleeding money on front office turnover while their physicians drown in off-hours documentation. As you run a solo, low-volume concierge practice, your message volume likely does not justify this kind of structural intervention. For the practices that do need this, deployment is rapid. You go live with your trained virtual team in just 48 to 72 hours, with absolutely no long-term contract lock-ins. You run an initial 2-week supervised phase. This includes extra quality assurance checkpoints and daily syncs to ensure accuracy and mitigate any operational risk before full handover. Ending the unpaid second shift is entirely possible. It just requires practice leaders to step away from a broken localized hiring cycle and implement a scalable virtual infrastructure.